Hello, welcome back to my YouTube channel. For those of you who are visiting my channel for the first time, I would like to introduce myself as Dr. Roja with the specialty in psychiatric nursing. I've been making videos related to different mental disorders. And recently we have been discussing about neurotic disorders. Under that we have gone through panic anxiety disorders, phobias, and recently OCD too. Now today we are going to discuss about dissociative disorders, conversion disorders. So those of you who haven't subscribed my channel, I request you to please subscribe it, and so that share to others, it might be informative for them too. Coming to dissociative disorders, we are going to see the definition, history, epistemology, etiology, clinical features, diagnostic criteria, differential diagnosis, investigations, course and prognosis, and management of conversion and or dissociative disorders. These two words are actually interchangeably used, but they mean the same. Coming to definition of dissociation. Dissociation is the mechanism that allows our mind to separate certain memories from conscious awareness. Now, we need to understand this term, disassociation. There is a split which is occurring. So, in this mechanism, what happens is certain memories, when we say traumatic memories especially, these memories are separated from our conscious awareness. That means we forget. Coming to dissociative disorders, they are described as disturbance in ordinarily organized functions of conscious awareness. Already we said. Next, memory is affected. Next, identity of the person. Apart from this, there are other subtypes also. We will go through them in detail in this video. Coming to dissociation, already said, some part of the memories what we have is separated from our consciousness. So it becomes inaccessible to our consciousness. So avoidance response. We don't know why we behave at certain times, why we avoid certain situations. So some types of dissociations are harmless and are very common, like losing track of time. And we will go in detail regarding the different types of dissociative disorders. In dissociative disorders, there is a disruption in the continuity of consciousness, emotion, where anxiety is produced, fear is produced in them, motivation is affected, memory is affected. The next, identity of the person is also lost. Understanding dissociation and memory. How does memory work under stress? So here, if you think of any situations where you are very much stressed and anxious, what happens? You cannot clearly think. You tend to lose some memory, or you tend where like you cannot recollect some memory. Let's put that way. Maybe when we are doing some practical exams, while answering for Viva, what happens? We suddenly get a thought block. Why do we get thought block at that time? Because we are very much stressed up. We have lot of anxiety. Even though we know the answers, we can't answer them because of thought block. In the same way, in dissociation, person who is under stress, these events are forgotten. They're out of conscious awareness. Next, according to psychodynamic theory, we will go in detail also. Traumatic events are repressed. So, according to Sigmund Freud, he had given different types of defense mechanisms, and he said there will be suppression and repression. Suppression occurs where a person consciously avoids recollecting a traumatic event. So, in repression, what happens is the person unconsciously forgets that event. So, next, coming to cognitive, extreme stress usually enhances rather than impairs memory. Next, interference of memory formation, not accessible to awareness later. Common features of dissociative disorder are disturbances in normal integrated functions of consciousness, identity, memory. Already we have discussed regarding that. The disturbance may be sudden or gradual. Disturbance is usually temporary, recovery is often abrupt. So when we say this disturbance is temporary, recovery is abrupt, in conditions like dissociative fugue, where a person loses his identity, goes away for to a far place, create new identity, live there for a few months or days, then suddenly he recollects back his memory, and he forgets the new identity what he has created and get back to the normal one. So this happens in dissociative disorders. Next, coming to the next point, dissociative disorders tend to occur in response to severe trauma or abuse, any stressful event. And then along with the stress and anxiety which is produced in them, they will have significant impairment in general and social functioning. Before we could diagnose a person that a person is suffering with the dissociative disorder, we need to do all investigations to rule out that there are no physical factors involved in this. So detailed physical examination is done, investigations are done, and if there is no abnormality found in that, then we can categorize them under dissociative disorders. Now we said dissociative and conversion disorders. These two terms are frequently interchanged. What is meant by conversion disorder? Conversion disorder is a subtype of dissociative disorder. So it is defined as presence of one or more symptoms suggesting the presence of neurological disorder that cannot be explained by any known neurological or medical disorders. What happens in conversion disorder? There are some neurological signs and symptoms, but in real, the person does not have any neurological or medical disorders. What causes this conversion disorder? Factors like stress, conflict. According to ICD-10, conversion disorder is subsumed under dissociative disorders of movement and sensation. Under this conversion disorder, we have certain types like dissociative motor disorders, dissociative convulsions, and dissociative sensory loss and anesthesia. Now, when we say dissociative motor disorders, the person might be having epilepsy or convulsions where only one side of the extremities do have the shaking or tremors, and other motor disorders like twitching, and they might be complaining of sensory loss of extremities, or they might be telling that they are not able to feel any sensation in their body. Coming to historical point of view, conversion disorder was almost described, clinically identified and described 4,000 years back. Hippocrates believed that this conversion disorder especially occurred only in women. So that's the reason they use this word wandering uterus. Originally, it came from hystero, that is hysteria, Greek word which is used for uterus, because this condition is specially believed to be attributed to females. It was in the 19th century that Paul Brigitte, he had described this disorder as a dysfunction of central nervous system. But later on, what happened is Sigmund Freud, he introduced the term conversion based upon his work with his wife, Anna Freud. He hypothesized that the symptoms of conversion reflect unconscious conflict. Coming to epidemiology, we said it is more common in females when compared to males. It is 1.3 in female and 9 in for 9 females. Prevalence rate is 1.3, average age is 30 years, and definitely there is a history of sexual or physical abuse, and over 70% of outpatients with the dissociative identity disorder have attempted suicide. Oh no, this dissociative identity disorder, that means they lose their identity when they have lot of confusion, anxiety, when they really do not know who they are, they have attempted for suicide. No one exactly knows the root cause of DID. DID means dissociative identity disorder. It is hypothesized or believed that repeated episodes of severe physical or sexual abuse in childhood contributed for development of DIDs. Innate ability to dissociate easily during childhood, extreme stress, other relatives with dissociative symptoms or disorders also. And now coming to comparison of somatic disorders, factitious disorder and malingering, we need to understand the difference between these three, because later after this we are going to discuss regarding somatoform disorders also. There is unclear or unexplained medical symptoms for all these conditions. Symptoms production in somatoform or somatization disorders is unconscious. Symptom production for these somatoform disorders is unconscious. Person really does not know. Here the motivation is also unconscious. Gain is none. I will explain to you what is gain. Next, coming to the other conditions like factitious disorder or malingering, symptom production is intentional. These persons will produce symptoms intentionally, but what happens in factitious disorder is motivation is unconscious. What made them to do such type of behavior, they really do not know. So the gain here is primary or otherwise called as internal. When we say primary gain, the stress or the anxiety which is in them unconsciously produces these form of symptoms like dissociative amnesia, dissociative fugue, or depersonalization, derealization. There are conversion disorders, convulsion, etc. All these are motivated unconsciously. And the gain is once they produce these symptoms, the psychological stress and anxiety in them is reduced. Whereas coming to malingering, symptom production is intentional, motivation is also intentional, gain is secondary. Gain is secondary means, I said first primary gain is relief from the psychological symptoms like anxiety and stress. The secondary gain is that some of the household works can be carried out, being away from their normal routine works and responsibilities is the secondary gain. For example, let me tell you, if there is a young lady who got married to a soldier and spent some time, only for maybe few months, with the soldier, and he left to the border, leaving that young lady with the in-laws, and she has to serve the in-laws, loss of love from the husband. At the same time she conceives, she is facing lot of stress with the in-laws as well as with the conceiving child. So she might be stressed up with the life, finding no meaning. But one fine day, if the husband return back from the border, one thing is, first day maybe she might be nice with the husband, but the next day she might fall in front of all the persons, and maybe husband will try to pay some attention what has happened and take to hospital. Then they might say that she is weak and she needs some rest, so husband will show a lot of love and affection, and as a result her primary gain, the stress what she had so far, is gone. But apart from that, she will have secondary gain also. The responsibilities what she has fulfilled so far, like taking care of in-laws, child and all, she will get exemption from that. That is the secondary gain. She can rest from that. So I hope you have understood. Next, coming to diagnostic criteria for dissociative or conversion disorders, we have these are classified under F44. So how we can just give a criteria for this dissociative disorder is like clinical features as specified for the individual disorder, no evidence of physical disorder. First itself is said. We need to rule out if there are any things like any we need to confirm that there are no medical illnesses. Next, evidence of psychological causation. And problems or disturbed relationships have to be identified. Apart from this, we have further classification also. Specific types of subtypes of dissociative disorders. I have said dissociative amnesia, dissociative fugue, stupor, trance and possession disorders, dissociative motor disorders, dissociative convulsions, dissociative anesthesia, sensory loss, mixed dissociative disorders, other dissociative disorders, and we have unspecified dissociative disorders. We are going to go through each and every subtype in a short form, short way. Coming to differential diagnosis, why it is very important. So, as mentioned again and again previously, we need to rule out that the person does not have any other medical conditions or any substance use disorders like dementia, other degenerative brain tumors, or brain any disorders involving neurological or brain pathologies, schizophrenias, depression and anxiety disorders. We have to differentiate this from that. Coming to subtypes like dissociative amnesia. Here the person will not be able to recall important personal information. Inability to recall important information, particularly concerning stressful or traumatic experience. Okay, for example, if we take a major accident has happened to that person, has happened to a person, and he got admitted to the hospital, and after he recovers from that, when he is asked what really has happened, the person might tell, I'm not able to remember anything. Only thing I can remember is we were traveling in a car and suddenly something came. After that, what has happened, I cannot remember, because that event is stressful and traumatic for the person to recollect. That is like dissociative amnesia. Under dissociative amnesia, we had other different types like localized amnesia, which says inability to recall events related to subscribed period of time, particular period of time. Then selective amnesia. When we say selective amnesia, ability to remember some but not all. Certain events which are occurring at a particular time, they are forgotten, but the other things they can remember. Next, coming to generalized amnesia, failure to recall the entire life of a person. Then continuous amnesia. Here, failure to recall successful events as they occur. Then at there itself, that event will be forgotten. Whatever happens, it is forgotten, like that. Systematized amnesia. Here, certain categories of memory is lost, such as relating to a particular person or family members. So, certain category of a person's life is lost, memory is lost. I hope you had an understanding about what is dissociative amnesia. Next, coming to dissociative fugue. Already I have explained. Here, the person forgets his identity. He will go away from home, maybe travel miles together, 1,000 kilometers or 1,000 miles, somewhere far away. He will create a new identity, stay there for a period of time. It might be days or months or sometimes years. And he live with that new identity. And abruptly, when he recollects his memory, he'll return back to home and he will forget the new identity which he has created for himself. This is called as dissociative fugue. Next, coming to dissociative stupor. So here, this is defined as profound absence of voluntary movement and a normal response to external stimuli such as light, noise, touch. But when he is examined or investigation is done, there is no evidence of any physical cause. That's when we can say the person is suffering with a dissociative stupor. Next, coming to trance and possession disorders. So, temporary loss of sense of personal identity and full awareness of surroundings is lost. You know, sometimes we say demon possessed or spirit possessed, where the person will behave like another person. So, those are said as trance or possession disorders. Next, coming to dissociative motor disorders. So, some of the commonest varieties, maybe we can mention them as abnormal movements or paralysis. And paralysis can be mono, para, or quadriplegia, where they say, I'm not able to have any sensation. There will be abnormal movements like tremors or choreoathetoid movements like hands just shaking, and they have gait disturbances where they just have some wavery gait, they cannot stand straight. So these either occur or increase when they feel that they need some attention. When group of people are there, they try to show these symptoms. Dissociative convulsions. So this we have mentioned like in hysteria or conversion disorder. Yeah, the person will be having hysterical fits. It is characterized by convulsive movements and the partial loss of consciousness. But we need to differentiate regarding this hysteria, whether they are real convulsions or hysterical fits. So we will try to differentiate between them. Coming to the first column is clinical features, the second one is epileptic seizures, and the third column is dissociative convulsions. Attack pattern. In epilepsy, it is stereotyped, and dissociative, absence of or any established pattern. Place of occurrence, anywhere epileptic fits will occur, but coming to hysterical fits, usually indoors or where place is safe. Warning, aura is present. And variable, you know, different stages of epileptic seizures, you say aura, clonic, tonic phase and all. So here in hysterical fits, we cannot see this aura face. Time of the day, if it is epilepsy, any time during sleep also, but dissociative fits does not occur during sleep. Tongue bite, it is present in epilepsy and it is absent here. Incontinence of urine and species in epilepsy, yes, can occur, but it's very rare in dissociative convulsions. Injury can occur in epilepsy and it's very rare in dissociative. Coming to speech, during epilepsy, they will not do any verbalization, but verbalization may occur during dissociative convulsions. Duration of convulsions usually about 30 to 70 seconds in epilepsy, but whereas in dissociative convulsions we have from 20 seconds to 800 seconds and can prolong. Then coming to head turning. In epilepsy, it is unilateral. Either the person turns head this left side or right side, one side. But in dissociative convulsions, head they will turn side to side in this way. Coming to amnesia. After epileptic seizures, person will have complete amnesia. He doesn't know what has happened. But in dissociative convulsion, partial amnesia occurs. Then post-ictal confusion is present. After the epileptic fit seizure occurs, then post time, what happens is confusion is there, disorientation is there. But whereas in hysterical fits, it's absent. EEG is abnormal in epilepsy, then it's normal in dissociative convulsion. Then if we check serum prolactin levels, it is increased in epilepsy and it is usually normal in dissociative convulsions. Coming to another subtype, dissociative anesthesia or sensory loss, characterized by sensory disturbances like glove or stalking anesthesia or blindness. Maybe some persons complain they are not able to see, and contracted visual fields as though they are able to see, or like only peripheral vision is lost, central vision is present, like that. Then deafness also is complained by these persons. Coming to other dissociative disorders, we have Ganser syndrome. Now, what is Ganser syndrome? Giving an approximate answer is called as Ganser syndrome. This syndrome is identified initially in prison inmates, prisoners. When they are asked any question, they will not give the exact answer, but they will give an answer which is approximately near to the truth. For example, I'll ask, how many legs cow has? You will tell it has 4 legs. But if it is a prisoner, he will tell it has 3. So the answer is near to it. Such a type of wrong answers to questions, okay, is called as Ganser syndrome. So for these persons, other dissociative symptoms also, subtypes might be present like fugue, amnesia, and they have pseudo hallucinations, decreased state of consciousness too. Next, another type is multiple personality. So here the person is dominated with one or more personalities, out of which one is manifested at a time. And the other personalities which are present in the person, he is not aware of the other personalities. One personality is presented at one time. Next, coming to another important one is mass hysteria. The person will behave hysteric. They exhibit symptoms similar to that of hysteria. But when we use this word mass, it occurs in groups. So mostly in school settings or factories or hospitals, where all persons in that group try to behave in a same way, such as having headache or nausea or dizziness or trance-like state or having seizures-like movements. It is believed like It may be some demon possessed or something, like some delusion, some witchcraft is done on them or something like that. So this is called as masked hysteria. Okay. Coming to, I hope you are able to get through different types of uh, dissociative or conversion disorders, their subtypes and all. If there is anything that you need me to just explain in a more, just leave in a comment box. We'll proceed with etiology. Coming to etiology, biological theories, they say under genetic theory, the concordance rate in monozygotic twins is high, and first degree relatives also it is high. Then physical illness or brain damage also can cause dissociative disorders. That's the reason first we need to rule out the, if there are any physical causes, then rule out the other way. Next, according to psychodynamic theory, often I keep repeatedly telling that psychodynamic and psychoanalytic theory mostly given by or explained by Sigmund Freud. He said when repression fails, it may lead to dissociative disorders. When the primary mechanism fails, it will lead to dissociation and conversion. You know, repression, it is defined as unconsciously forgetting the things. So when this fails, the symptoms are produced or shown outside as a secondary mechanism. Next, coming to behavioral theory, they say that we believe that all behavior is learned. So this might have been learned from the parents, classically conditioned learned behavior where from childhood it might have been observed in the family and the environment where the person stays. Coming to diagnosis part of it, we need to rule out the physical disorders, any substance abuses, then we have to use ICD criteria, and there are certain standard tests for dissociative disorders, like dissociation experience scale is there, dissociative disorders interview schedule is there, and physical examination, investigations. Basing on all these, we can diagnose the person with what he or she is suffering with. Coming to investigation, what sort of investigations do we need to do to the person? So we need to rule out electrolyte imbalances, hyperglycemia, renal function test, toxins, systemic infections, other drugs, CT scan, MRI scan, chest x-ray, EEG, lumbar puncture. All these tests are done to rule out if there is any underlying pathology physically. When these come negative, then they go for psychological testing. Coming to treatment modalities, we have free association. Free association is given by Sigmund Freud. In this, what we does is that we ask the person to relax himself, and what we will mention a word and ask the person immediately what he remembers when we say that word. Free association. Now, for example, if I say rose, the person might answer beautiful, or other person might answer red, like that. So for a child who has been physically abused by a stepmother and who has been admitted in hospital with a dissociative disorder, when we just do this free association test, we go from neutral words. So we might be asking school, friends, and later on when it comes to mother, the child might say devil or something like that. So we can free advise and explain to them whatever comes to their mind when we say a word, and we take that whatever they say into an account and associate and try to identify the underlying cause. Free association, that is said as free association. Next is hypnosis. Here it is done by a hypnotherapist where the person is made to relax. He is taken into a trance situation by giving certain suggestions. Then the person is asked to go back into his life where what has caused him the stress, and thereby the person will try to ventilate the things. And here the person can is suggested or advised on some relaxation therapies and how to cope up with stress during hypnosis. Next, coming to abreaction therapy. Abreaction therapy, it is like a therapy where the painful repressed feelings are purged out or brought out by using hypnosis. But here, because if this doesn't work out, they'll use injection, sodium pentothal injection, or IV diazepam is given to the person, and he is taken into deep sleep, and he is taken back into trance, and before he could go into deep sleep, he will be asked to ventilate whatever is causing a lot of stress in him and a lot of strain, and how was his childhood, and which part of his life was painful for him. This is how abreaction therapy is done, and this is also done by a specialist. Next, coming to supportive psychotherapist. Here, it involves providing support to the individual by using different types of support systems, what he is having, and what support systems are available. He will be guided through that. Next, coming to behavioral therapy, if there is any behavioral abnormality, there are certain means methods where like shaping, chaining, and all. So we can use these types, any method if there is any abnormal behavior to correct the person's behavior by modeling, chaining. uh, Next, we have drug therapy. Most of the time, drugs which are prescribed for these persons are benzodiazepines, and we have been seeing regarding benzodiazepines from the time we have been discussing related to neurotic conditions. Like in anxiety, we have discussed about benzodiazepines, and under phobic anxiety disorders, we have discussed about benzodiazepines, and in OCDs also we have seen like some of the benzodiazepines like lorazepam, clonazepam, oxazepam, and diazepam, alprazolam, all these drugs which reduce anxiety in a person and which produces calmness to a person, these drugs are prescribed. So I hope you have got an idea of what are these dissociative and conversion disorders. And we have discussed about various etiological factors, and we have discussed about different subtypes of dissociative disorders, and also the ICD criteria for diagnosing and differential diagnosis, and what type of investigations are needed to be done before we could confirm that the person is suffering with dissociative disorders. And we have discussed about various treatment modalities. We will stop for now this video. In my next video, we will discuss about nursing management of dissociative or conversive disorders. I hope you have understood this video. So we'll stop for now. We'll get back soon. Hope to see you soon. Thank you all very much for listening to my video.